trauma fundamentally changes how we think, how our body responds, how our emotions react to different situations. And it can impact us in all of these different areas of our body and our mind and our life. And we have to first and foremost help people feel safe again.
You're listening to Conscious Mind, a show that explores what fascinates us.
Hi, I'm Molly Norton, Director of Quality and Experience at Silver Hill Hospital. Welcome to episode 3 of Conscious Mind. Today I'm joined by Dr. Emily Haas. She is the director of our Trauma Transitional Living Program and an MD here at Silver Hill. Fascinating person, has a lot to tell us today about the treatment of trauma and how she sees this field and the world. Welcome, Dr. Haas.
Thank you. Thanks for having me.
Thanks for being in the studio today. So trauma is that's a big word with a lot of meanings. And I imagine the work of treating people with trauma is incredibly deep and intense. And so my first question for you is, I'm curious what drew you to this specific subspecialty of psychiatry. Why trauma? What got you interested in this specific thing?
Yeah, so it's a little bit of a story. I first got interested in becoming a psychiatrist back in medical school. And I was majoring in psychology, interested in the mind, understanding human nature, understanding how people think and act. But I wasn't sure if I was really living in a fantasy or that I would really enjoy being a psychiatrist or not. So I started volunteering for the program for assertive community treatment in Madison, Wisconsin, where I was training at the time. And there I worked mostly volunteering with people with severe schizophrenia who were out in the community. And I was doing things like taking these individuals to the grocery store and helping them shop and taking them to their doctor's appointments. And it was super fascinating and I really liked it. And what I enjoyed about it was how fascinating each of these individuals were and how, given how severe their mental illness was, they were still able to function and live full lives. And I just really enjoyed getting to know them and kind of the complexities of how their mind worked. And so I ultimately did go to medical school and there I, specialized in psychiatry and thought I was going to be a community psychiatrist working with these patients. I just happened to take a trauma psychiatry elective in my second year of residency and loved it immediately. I was super fascinated by all of it. I was coming to know myself as a mental health provider and realized that I actually really enjoyed psychotherapy. And so what I found to be true when rotating on the trauma unit there was that these individuals have really complex symptoms, really complex minds, and the treatment is psychotherapy based. So it was kind of the blending of everything I liked. Was they have pseudopsychotic symptoms, they have trauma symptoms, they're depressed, they have substance use issues. They have these really complex clinical histories, and I get to treat them with my mind primarily, right? I get to use medications to supplement the treatment, but it's really coming from my mind through therapy. And so that's kind of where I got interested in it. And then I just pursued a lot of different opportunities to work with these patients throughout the rest of my residency, and then ultimately worked as a trauma psychiatrist right out of residency and have loved it ever since.
It's interesting. I feel like not all psychiatrists are drawn to psychotherapy, and it seems to be something that back in the day, 50 plus years ago, all psychiatrists did psychotherapy. And I wonder, in your opinion, are things kind of moving back in that direction? Like for a period of time, it was very much med management was really the major role. Do you think there's a place, or you think culturally, you think that will change at all?
Oh gosh, I hope.
Yeah.
I hope that more psychiatrists really start to incorporate psychotherapy into their practice. I think with all the changes that have happened in different health systems and insurances, that really pushed psychiatrists into the medication management role only. And also, we do have a deficit of psychiatrists. There's not enough providers for patients who need the help. And so systems and insurances and even providers kind of have to go faster and see more patients in shorter periods of time. I personally would never work in a situation where I have to do that because the psychotherapy is so important, in my opinion. And I hope that our health system can move in a direction that supports psychotherapy from a psychiatrist as well, and not that those individuals have to only be in private practice to be able to do that.
So when it comes to trauma treatment specifically, are you of the mind that therapy is more important than meds?
Oh, yeah.
The same amount?
Definitely. No, psychotherapy is the mainstay of trauma treatment. And I will tell patients that. I'll say, hey, as your psychiatrist, I'm actually the least important person on your team. And, that kind of gives them some context that, yes, the medicines are important, but their therapist is the person who is really driving treatment. That's why I consider myself a psychotherapist, psychiatrist, so that I can really help them move forward.
So what's the magic and the sauce there? What about talking through your trauma makes it so effective?
Good question.
Yeah,
It's complicated. It's trauma. In trauma means a lot of things. So let's start there, right? You mentioned that earlier. And not all traumas are made equal, right? So having a trauma of being in a severe car accident impacts someone differently than child abuse, having it been a survivor of child abuse. And the treatments for that are different, right? So largely we can apply the same principles, but how they respond, how intensive the treatment needs to be, how much psychotherapy they need or not is going to depend kind of on what sorts of trauma experiences they've had. So for people who have had trauma that's primarily interpersonally driven, right, they've been hurt by another person, part of healing has to have an experience with another person that is safe, right? And so trauma fundamentally changes how we think, how our body responds, how our emotions react to different situations. And it can impact us in all of these different areas of our body and our mind and our life. And we have to first and foremost help people feel safe again, right? And that can't happen with medications, right? Just taking Prozac doesn't make you feel safe in a room with other humans. Being in a room with a human who is safe helps you feel safe again. And so that's why we can never successfully treat traumatized individuals without therapy, because we have to show them safety.
So basically they're relearning safety.
Very much so.
Yeah. And I feel like that's true for other treatments, like anxiety treatment, exposure therapy, things where you kind of have to override that side of your brain to learn that I can be in this situation and be safe. But without having that experience, and in this case with another human, your brain can't really get to that place.
Exactly. One of the main symptoms of PTSD is impulses to avoid things that remind you of trauma, or experiences or settings or environments where trauma happened. And an expression I use a lot with both my team and patients is, we can't collude with your avoidance, right? If I engage with you or let you kind of not go to groups because you're scared of being around people, we're never going to help your PTSD getting better, because we're letting the PTSD symptoms win, right? But again, that's where the interpersonal element is so fundamental to being able to work on this.
Yep, absolutely. In terms of trauma in general, are you of the mind, and I'm sure you've been asked this before, do you think every one of us has trauma to an extent, and that for some people it's just a lot more?
Yeah, I mean, we all have experienced different things that we could qualify and consider traumatic. And that's why when I'm actually talking to patients and meeting people, I don't actually ask them, have you experienced trauma? Have you experienced abuse? Because that would just be me asking them, do you define trauma and abuse in the same way that I do? And oftentimes they don't, right? I have to do a lot of psychoeducation about certain experiences they describe as being emotionally abusive, right? And so we all have different experiences that impact us negatively in ways that we could consider traumatic, right? We could argue that all of us as a whole world just went through a collective trauma of the pandemic, right? A lot of us have changes in how we think, how we feel, how our body responds to different stressors because of the pandemic, right? So we all have that. It just is about how it's impacting us, what our vulnerability factors were at the time, and how different supports in our life are present or not, and how that may impact how severely this impacts us.
Vulnerability is an interesting concept, because I think one event can happen to two people at the same time, and one person can have a severe trauma response while the other person is seemingly okay. So there's something, right, that's either biological or someone may be predisposed or more vulnerable to a traumatic event, right?
Exactly. A lot of the kind of people who research this, they really kind of talk about it through the lens of resilience. I personally don't like that term because I find that it implies that you are resilient or you are not, and therefore if you're not, there's something wrong with you. That's why I think it makes more sense to use the term vulnerability, right? Like if you are a child who is in a dangerous situation and you have a loving, supportive, caring family who can support you and help you manage your emotions after that, it's going to impact you differently than if the family and caregivers are absent and there's nobody to help you manage your emotions and to help you understand what you just went through, right? So I think that child is more vulnerable. Like, I don't personally like the term to think they're not as resilient.
Do you think we can prevent trauma? I read something once, and this was a few years back. It was something about immediately following a traumatic event. There was some research that was done where if patients received a certain kind of calming medication, I think it was propranolol or something, just after the event, that in some cases that prevented the prolonged trauma response. What do you think about that idea that we can kind of get ahead of trauma materializing in someone if we can intervene?
Well, I think we're talking about two different things. I think it's those studies, they're hoping to talk about and demonstrate that we can decrease the severity of symptoms after trauma, the severity of how trauma impacts our mood, our thoughts, our flashbacks in our body, those sorts of things. That's different than preventing trauma, right? I think as a society, we are always going to encounter people who have dangerous impulses or who have desires to do things that are dangerous to others or disregard for others. So I think the concept and the idea of being able to entirely prevent trauma is one that might be a little bit of a fantasy, right? That there are wars happening in right now, right? There are things happening that are going to be traumatizing all the time. I think thinking and continuing to explore and understand the different ways we can lessen the severity of how that impacts us is very important, though. But I also want us to think cautiously about that, too, is that it could lead someone who had that treatment, say it was propranolol, right, who had that treatment and still is strongly impacted, to have greater feelings of shame if they had worsened symptoms despite the treatment. So I think every element of trauma treatment, we have to think about what are the potential implications to how this makes someone feel and think about themselves if they don't respond in the same way or they still suffer after that. And so I think when we're designing trauma treatments, researching trauma, that's an important part of the equation.
Yeah, you can have a tool in the toolkit, as they say, but it's probably one thing is not going to be the answer to any of this because it's really complex.
Right.
So in terms of your work at Silver Hill and what drives you and when you feel really good and connected to the work that you do, what kind of keeps you coming back to this field and the treatment specifically? What do you like to see? What do you like to experience in your work?
It's innately incredibly rewarding to work with people with trauma and helping them get better. I often get the question of, Dr. Haas, how do you hear all these stories and how does it not impact you negatively? And aren't you vicariously re-traumatized through these experiences? And actually the answer is no, I don't feel that because I have really careful boundaries about what we are getting into in terms of discussing someone's trauma narrative. But it's so much so that when someone comes in and they've been so severely hurt by another human and I get to help them have relief from that, it's so very much rewarding. And that makes every single difficult day worth it. And you get to see someone come in feeling the worst they've ever felt and leave feeling like a new person. And that's just amazing.
I think that makes you a special person, too, that you can hear these really, really difficult things and you can sit with that without having a outward emotional reaction of your own. And not everybody can do that. So it seems to me that you're fit for this type of work, that not everyone can do this.
I think there's a little bit of truth to the fact that there are certain people who would have a harder time not internalizing the stories that they hear. It's a little bit easier for me to do that, but I also set my life up to make that possible, right? I do not watch the news. I refuse to watch the news because I don't need to hear any other stuff, right? When I go home from work, that's a time for decompression, sharing times of joy and comfort with my husband, and not watching and hearing about other things that are happening. So that makes me a little bit more disconnected to things that are happening in the world, but it makes me able to sit with the patients that I have.
No, that's smart. You have a tolerance for how much you can take. I mean, I think we all have like a tipping point when we just have to shut it off, or we're like, okay, we have a reservoir and the reservoir is empty and we can't take anymore. So it's good to know that.
Yeah, it's actually hilarious. Last night I was watching the news a little bit before bed as a different show had ended, and I was like, what am I doing? Turn this off. I'm just hearing about all these terrible things. I don't need to add to the pile.
No, comedy only, relaxing things after work. So I always like to ask people about what's on the horizon and what's in the future for the type of treatment that they practice. What do you think the field of trauma treatment may look like in 10, 20, 30 years? What are your hopes for how we progress in the field?
Yeah, so I think mental health in general is catching on that trauma is important to pay attention to, right? You hear now more and more different institutions, different programs saying they're trauma informed, right? And so people are starting to think we have to consider this even if we are a substance use program or an eating disorder program. We have to think about trauma. That's great. But there's a difference between being trauma-informed and being a trauma treatment program, and they have fundamental differences in different supports offered or not. What I think the future includes is, I think more and more people are trying to find new treatments. They're trying to find other treatments, more sorts of interventional treatment options. And I think that's because sometimes trauma, if you're not really adequately trained in how to treat these patients, it feels overwhelming. Right? They have complicated symptoms. They don't get better from certain treatments if they're not getting the right treatment. And so that leads us to want to search for more and more and new things. And I think that's good because we won't advance if we're not being curious. But I think in my hopes, I hope that we never get so far in our mental health system that we lose sight of psychotherapy, right? To me, it always is going to come back to that even if we have all of these other new modalities and they have merit and value, I think we can't lose sight of the fact that just regular talk therapy is still so fundamentally important.
Do you think some clinicians, perhaps people that are newer in their career, do you think they worry they may re-traumatize people through the treatment if they're not doing it right? I know way back when I was in school, when we studied, I think prolonged exposure was what we used to use for treatment of PTSD, and I think CPT has kind of taken the lead there. There was a lot of warnings, at least from our professors, that was you really need to do this right. You have to be really careful. You don't want to re-traumatize someone. What are your thoughts about that?
I think it's a double-edged sword. I think there is truth to the fact that these individuals are vulnerable. They've already been hurt, and because they've often grown up in situations where boundaries were poor, they don't know when poor boundaries, or they have trouble detecting poor boundaries, again, in other situations, right? So they are more susceptible to be taken advantage of or for difficult things to occur in terms of a therapeutic relationship. So we have to keep that in our mind. But I think sometimes that message of be cautious, be careful, you could re-traumatize these patients, becomes so much at the forefront of a therapist, especially a younger therapist's mind who hasn't maybe had as much training in this, that it actually makes them afraid of working with these patients or too cautious that they're actually not making interpretations that they should be because they're worried the patient will be unsafe or whatever it may be. So I think it's a double-edged sword. I think we have to be very careful, and I think the solution to that is that we need to train providers more fully on understanding trauma disorders, and especially dissociative disorders. Most places don't have any training in that, and dissociative disorders are far more common than people understand or really recognize. So I think we need to train people better and then help them balance more the true vulnerabilities of these individuals with the fact that they can also be pushed. They're also adaptive. They've survived a lot already.
And for those of you listening, Dr. Haas has done extensive training with our staff. And so everybody that is working in our trauma program is fully trained personally by Dr. Haas, which I think is really important. They are able to download all of her wisdom and knowledge on this before actually working with the patients, and a very close-knit team in the program, which I think is so important when you're discussing cases and people's lives and making sure that everybody's on the same page. You mentioned dissociative disorders. And for our audience, I think it would be interesting and educational if you could talk just for a minute about dissociative identity disorder, what people formerly knew as multiple personality disorder. I think it's something that you see a lot in the media and probably misrepresented or dramatized, and what you wish the general public knew about folks that struggle with dissociative identity disorder.
Well, I wish media would stop portraying them as literal monsters. That would be a great start. I think it would be phenomenal if we could widely disseminate the knowledge that dissociative disorders, and especially dissociative identity disorder, is a condition of secrecy. It's a hidden adaptive illness. These conditions are incredibly hard to diagnose, which is why these patients often go through many different types of treatments without much success, because it's something that has protected them and helped them survive trauma, and it's something that's incredibly subtle. These kind of media portrayals of someone switching to this monster-like figure from someone who's this young childlike figure is not at all accurate. It's overtly harmful to portray people in that way, actually. This is something that's really, really subtle and is actually far more common and prevalent than people recognize.
Dr. Haas, thank you so much for your time, for your advocacy, for your hard work that you're doing with launching this program. If you all only knew how much work and blood, sweat, and tears have gone into the development of the program, you would be just as impressed as we are. So thank you for being here today and for giving us your precious time to talk to us about the great work that you do.
Of course. Thanks for having me.
You've been listening to Conscious Mind on Silver Hill Radio. We'd love to hear from you. For questions and content submissions or ideas, please email us at silverhillradio@gmail.com.